Hey guys, Aaron Boster here. It is a Saturday morning, 7:20 about, and I just wanted to jump online and test out the different options for live streaming here on YouTube. I haven't announced that I was going to be live streaming. I did put out a community question to see if anyone was interested. And here's a Gift Boutique saying good morning. Good morning to you. Gift Boutique, can you hear me okay? Please write a comment. Let me know if you guys can hear me okay. Lorna says hi. Gift Boutique says she can hear. Amber Raver's up. Amber, how are you? For those of you that aren't familiar with Amber, she is my amazing medical assistant at Ohio Health, where we see folks with MS. And she's recently helped me out quite a bit on the YouTube channel, allowing me to record as I did a screening neuro exam on her. So there's a video that I published earlier this week where you can see me doing a neuro exam on Amber and kind of break it down for me. Hey, there's Mario. How you doing, Mario? Mental MS. Good morning. Good morning, everybody. I wanted to jump online and say howdy hi and offer you guys and ask me anything MS. And so I've done this a couple times before. I really think it's fun. And I'm hopeful that you guys will enjoy it as well. Just a couple ground rules. I don't know very much about love. I don't know a lot about politics or sports. But I know some stuff about neuroimmunology and about multiple sclerosis. And so I'm going to hope that we kind of limit our conversation to MS. Also, I'm not able to diagnose you on the internet. I can't have you write in some questions specifically about you and have me give you a meaningful medical answer. So please keep in mind that this is an open forum. Please make sure that your questions are general questions. I've got Sarah saying hello from Sweden. Sarah, how are you? Coming soon, later this year, we're going to be headed out to go to Ocrevus, which is a neighboring country in Norway. Who else is on here today? A lot of cool people. AJHR, good morning. How are you? So this is awesome. It is so neat that there's this growing online community. Hello, Jim. How are you? And I want to use this opportunity to answer some MS questions. So if someone could fire off the first question, from Morocco. How are you? It's great to see you. I've spent a couple summers in Morocco, in Casablanca. I travel around a lot with my friends. Morocco is one of the most beautiful countries I've ever seen. And so thank you very much for joining me. Ça me fait grand plaisir de parler avec vous aujourd'hui. Le Maroc, ça me fait quelque chose dans mon cœur parce que c'est un pays extraordinaire. So Catherine writes in, I enjoyed your leaky pool video. Thank you. How does PPMS fit in with this theory? That's going to be our first question. So for those of you that are not indoctrinated into the theory of the leaky pool, a close friend of mine, a guy named Stephen Krieger, who is an associate professor at Mount Sinai, is an outstanding MS neurologist. And his contributions to the MS field make me feel proud that he's my friend. He developed this topographical model of multiple sclerosis, and I refer to it as the leaky pool model. I've done several videos on this. I'll make sure that I include some links when I edit this video later so that you can check out the leaky pool model. The leaking pool model of MS accommodates any form, flavor of multiple sclerosis, including primary progressive MS. Now, without visuals to draw for you, it's a little bit hard to share that with you, but I will include down in the link below a timestamp so that you can jump in one of my videos and see the section where I talk about progression and about how the leaky pool helps with that. Gift Boutique writes in, my adult kids are in denial about my MS. Gift Boutique, that's extremely common. And, I think one of the issues with multiple sclerosis is that it's invisible. It's really like an invisible condition. And so oftentimes, honey, you look so good. And you tell someone, oh, I'm tired. And they say, oh, yeah, I'm tired too. And they don't really genuinely understand. And that's a major problem. One of my favorite ways of addressing families that don't get it is to invite them to attend a clinic visit. I'm a big believer that you don't have MS by yourself. You have it with your village. And the onus is on you and me to help educate village members, including family members, and to help them understand the realities of this disease. Showing a spouse or a child or a parent the brain MRI, showing them the brain damage, having them watch a full neurological examination so they can see the deficits, talking and listening to us talk and discuss the pathologic fatigue and the cognitive fog and the other invisible symptoms sometimes helps sensitize them. And so those are just some ideas. There's also some really cool comic books out there. There are these really neat comic books that can kind of explain MS. And I don't mean to promote one product over another, but there's a series of books called MediKids, MEDIKIDS, MediKids. And it's a really cool series of comic books that tackles complex diseases for children. And I love these books. The MS book is fantastic. I've certainly looked at it with my children, and it's appropriate for adults also. So just a couple different ideas. Gift Boutique, this gives me an idea for a video to kind of talk about how we can help our children, our spouses, our parents better understand the diagnosis. So Jason Gregory writes in, what's the best way to limit fatigue? So managing fatigue, Jason, is a monster. It's a really big topic, and I'm going to spend a few minutes talking about that. Hey, Candy, how are you? So MS fatigue. Fatigue is the most common symptom in MS. It occurs more than any other symptom, and it's one of the leading reasons that people leave the workforce. So let me throw out 5 ways that we can combat fatigue. Number 1, take a disease-modifying therapy, Jason. Taking disease-modifying therapy quells inflammation in the holiest of holies, the brain, and taking a DMT can improve fatigue. And this has been well proven in clinical trials. And so I can't stress that enough. If you're not taking a disease-modifying therapy, you're asking for unchecked fatigue. And in my experience, when you upgrade to a highly effective disease-modifying therapy, sometimes we then do a better job of controlling fatigue. So that's the first one. The second one is to make sure that you're sleeping. Now that sounds silly, but a lot of us don't get adequate sleep. And so if you're sleeping 4 or 5 hours a night, that's not enough. And you're going to be making yourself fatigued, not because of MS, but because of poor sleep. And this extends to other aspects of sleep. For example, if you have obstructive sleep apnea and it's not treated, if you have restless leg and it's not treated, if you have a neurogenic bladder and you're getting up to pee 5 times a night and you're interrupting your sleep, that's not going to work. So spending time better understanding your sleep, making sure that you have good quality sleep, making sure that you have good quantity sleep, that's underappreciated. And it can make a world of difference if you get a solid 8 hours compared to 4 in how you're able to function the next day. Keep in mind that in the setting of MS, your functional reserve isn't awesome. It's not what it was when you were 18. And your functional reserve, your nervous system's ability to withstand lack of sleep or infection isn't as big as it once was. And so getting your sleep is all the more important. I said I'd do 5, and that's 2. So let's do another one. Exercise. Now you might think I'm crazy, Jason. You might say, whoa, I can't exercise. I'm exhausted. But paradoxically, if you can slowly build up your endurance to exercise, you find that it pays massive dividends in controlling and improving fatigue. And for starters, you might simply walk around the block, and you might walk for 2 minutes. And over the series of days or weeks, as you practice walking for 2 minutes, you'll eventually get to the point where you can do 3 minutes. You want to very slowly increase your exercise endurance. Now, I have videos on my channel that talk about sleep hygiene and proper sleep and sleep disorders. I have videos that talk about exercise. And so if you haven't seen those, check those out. I said I'd do 5 things to help improve fatigue. So far, we've talked about taking a disease-modifying therapy. We've talked about making sure you get adequate sleep, good sleep quality and quantity, and also exercise. So let's do 2 more. All too often, we doctors give patients medicines with good intentions that have side effects of fatigue. And so reviewing your medicines carefully to make sure that there aren't a bunch of medicines that make you tired. And these can be things like antispasmodics like baclofen and Xanaflex. Some of the antidepressants and anti-anxiolytic medicines can do this. Some of the bladder pills can do this. So streamlining your medicines and avoiding polypharmacy is another great way to improve fatigue. And I want you to consider that. Let's throw in one more. So far, to manage fatigue, we've talked about taking a disease-modifying therapy, getting adequate sleep, exercising, and watching out for medicines that can contribute to fatigue. The last one is managing depression. And Jason, you might say, I'm not depressed. Well, good. But all too often, people have undertreated depression. They have some depression. And one of the major manifestations of depression, I find, is fatigue. If you treat the depression, the fatigue improves. So thank you for that question. Now I'm going to run over here and take a look at some of the other fantastic things that people have written in. Tend writes, can frequent panic attacks and derealization attacks cause or worsen lesions? No. Panic attacks are awful. They're super scary. They're terrifying almost by definition, but they won't make your MS worse. Now, they'll ruin the quality of your life and you want to treat them, but they won't make your MS worse. Jim writes that he's a world champion napper. Well, there you go, brother. I'm a favorite napper as well. So moving along, let's see what else I've got. So AJHR, I love you. I love your comments on the channel. Thank you so much for participation. And you write, there was a new study published via Multiple Sclerosis News Today, and I'm on Tysabri. Recently released research on those on Tysabri about decline in brain volume and gray matter atrophy thoughts. I'm not sure which study you're referring to. Now, Multiple Sclerosis News Today is a news channel. So they take scientific literature and they summarize it. And so I'm not sure which article you're looking at. I do want to point out a couple things that you bring up. Number one, Tysabri is a highly effective medicine. I like Tysabri. And I'm not massively impressed with its ability to slow brain volume. Now, that might be because when we studied Tysabri in the early 2000, 2002 range, we didn't know a lot about atrophy, and so we didn't adequately study it. But the clinical trials that have come out to date looking at Tysabri, the one chink in its armor is its ability to slow down atrophy. Now, that's my own personal opinion, and it doesn't make me right, it just makes me opinionated. And so let's look at a couple other questions. I've got Divine on the line. How are you doing? I've got Dominique saying hello, howdy, hi. And what else is going on? So Dara, how are you, good friend? So depression can creep up on you without knowing it. There is no shame in telling your doctor that you need help. I did this last September and I'm now on a small dose of antidepressants. Sir, you bring up a most excellent point. And let me take that a step further. I, Aaron, suffer from depression. I have most of my teenage years and all of my adult life. And when I take an antidepressant, it is life-changing. Quite literally, there's been times where I'll forget to take it because I'm a human, because I'm a boy, and I may not take it for a couple days, and I can start to tell. It's remarkable that when my depression is treated, what a change in my life it makes. Depression colors everything gray and ugly. And there is no shame in admitting that you have depression. I just admitted that to you. And getting treated can be life-changing. So if you're sad, blue, and depressed, you're not the most awesome version of you, and you want to try to up your game, talk to your doctor. Tell them that you're feeling sad and blue. I'll also share with you that in the setting of having multiple sclerosis, you are 2 times as likely to suffer from depression compared to the general population. So what else do we have going on over here? Judy writes in, hi there. I'm 63 years young. I love how you said that. And after years of MS type symptoms, my doctor has arranged for an appointment with me with a neurologist. I thought that I was too old for the diagnosis. Well, Judy, thanks for jumping online and talking with me in this live stream. The average age of diagnosis of MS is 30 years old. Now, depending on which paper you read, it might be 29 or 31. But the point is that's 3 decades younger than you are. And it's true that we don't commonly diagnose people with MS at 63, but we do it. I've diagnosed someone as old as 78 with MS. Now that's exceedingly rare. I've also diagnosed someone that was 6 years old with MS, and that's also rare. And it's kind of a bell curve, with most people having onset of disease in 30. But you, Judy, are not a group of people. You're one human, you're one individual. And whereas MS is much less likely when you're 63, it's not impossible. And so I hope that you're going to see a wonderful neurologist that will listen carefully to your history, will do a proper neurological examination, will obtain proper neuroimaging, and do their very best to accurately diagnose you. I love all these people jumping online. It just warms my heart. Let's see what else we have. We have John writing in. My wife has MS. Doctor wants to start on Ocrevus. What is your opinion? Thanks. Wife is concerned with side effects. So John, full disclosure, I really like Ocrevus. I was a clinical trials investigator for all 3 of the phase 3 trials for Ocrevus. I've prescribed a lot of it. I've lectured for the company. I consult with them. I really like Ocrevus. And in some ways, I feel biased because I feel very strongly that it's an awesome medicine. Now, that doesn't mean that it's an awesome medicine for your wife. And if she has concerns about the side effect profile, that's reasonable. What we want to do with every single human with MS is get you on the most effective disease-modifying therapy that you're comfortable with. Now, the most effective disease-modifying therapy that you're comfortable with might not be the most effective medicine, but it's finding that risk balance. And so how do you do that? I have a bunch of videos on my channel about the various disease-modifying therapies, several videos on Ocrevus. One of them is my most well-attended video with one of the most views. And if you and your wife haven't seen that yet, jump on the channel, and I have an entire playlist dedicated to Ocrevus, and you can check that out. And so Daryl writes in, good to see you, Doc. You're such a gentleman. I spoke to my local doctor this past week, and he teaches trainees doctors. He is now advising them to watch you. Oh, wow. That is really, really cool. When I was in training, I was taught that if I don't publish papers, I can't be a good doctor. Because if I saw one family, I get to help one family. But if I write a research paper, my mentors would say, well, then I would touch thousands of lives. I don't know that I fully agree with that. And I think it has a lot to do with who you're trying to reach. So I've published about 40 scientific papers in the medical literature, and, good job. But my patients don't read those papers. Their families don't read those papers. And whereas it allows me to have mental sparring with other academicians and physician scientists and doctors, okay, that's not my goal anymore. That's not what I'm trying to do here. What I'm trying to do is reach out to people impacted by MS and make them the most awesome version of them possible by sharing medical education. And so I really feel like YouTube is a super great way of doing that. It's one of the best uses of social media for me, Aaron, to be able to reach out and help folks. And the fact that there are people that are not my patient, folks in other countries who I will never get a chance to help directly. I'm not going to be able to see them in clinic. They can't fly to Columbus, Ohio and see me. The fact that I might be able to impart upon them some MS education means the world to me. So thank you for talking to your doc, and thank you to that doctor for recommending this video. There's Josh Verdi. Josh, what's up, my man? You're a fantastic dude. Thank you for jumping online. What else do we have here? Alex is online. What's up, Alex? It's nice to see you. There are so many friendly faces here. So Alex writes, fluoxetine support reduce brain volume loss. That's pretty cool stuff. Fluoxetine is the code name for Prozac. And I haven't seen compelling evidence that Prozac improves brain volume, but I have seen that Prozac is a very inexpensive and highly effective SSRI antidepressant. Cheryl writes in, Genentech should have doctors that can look at patients' records and prescribe Ocrevus for patients who have issues with their neuro. I don't know about that. I don't think that I want the manufacturer to get involved in prescription. Fat to Matt, what's up, my man? It's great to see you. I see you love it. I love seeing you on here. Valerie writes in, how does a doctor come up with the best MS med for each patient? I've only been on Gilenya, and what do you think of Gilenya? Well, first of all, Gilenya is a great medicine. I was involved in the clinical trials that led to Gilenya's approval. It was approved in October 2010, and it's a once-a-day pill for MS, and it's a solid pill. I don't think it's the most effective drug. For Aaron, in my personal opinion, I place it like fourth. When you consider there's 17 medicines, that's a really good medicine. I like the fact that Gilenya is a once-a-day pill. And so for someone with an active lifestyle, particularly someone that travels, that's pretty easy breezy. How do you pick the right drug for a patient? I have several videos on this topic, and I'll share with you very briefly how I do it. It doesn't make me right, but you're listening to my live stream, so I'm allowed to share with you. And the way that I do it is as follows. First, I need to take a careful history. I'll spend a half an hour to an hour talking to the patient, the family, and I need to not only understand their MS, I also need to understand life goals. We have to talk about life goals. I have to understand what you're trying to pull off in life. I want to climb Monte Picchu. I want to stand at my son's graduation. I want to walk my daughter down the aisle. I want to work until I'm 65 or until I choose not to. I want to get a promotion. I need to know those life goals because we're going to use those life goals to frame our MS goals. I also need to understand your own risk aversion and your comorbid conditions, which might preclude you from medicine A or medicine B. I need to do a full neuro exam and I need to look at your imaging. And once I have a genuine sense of your MS, then we're going to start to talk about medicines. Now, we don't just use medicines to treat MS. I mean, that's crazy. Treating MS is a comprehensive thing. It involves a lot of behavioral changes. We have to pay attention to diet and exercise and not smoking. But drugs are relevant. They're very, very important. And I have a whiteboard in every one of my rooms. So I'll write up on the whiteboard the 4 most effective drugs, in my opinion, for that individual. So those 4 drugs might be different for the first patient I see as compared to the second patient because it's specific to that person. And I will talk about the good, the bad, and the ugly. I'll talk about of that first drug, of the drug that I think is the most effective. So the top one on my list, I'll tell you everything there is to know about it, and we'll discuss it. And if you agree that's the drug you want, sweet, we did it. We'll start on that drug. If you, on the other hand, say, I'm not comfortable, then I will go down a level. I will downgrade to something that, in my opinion, might not be as effective. And I will then tell you the good, the bad, and the ugly about that medicine. And if you like that medicine, then we'll pick it. There's Emily Craig. Hey, Emily, how are you doing? Nice to see you this morning. And there's Diana. How are you, Diana? Now, I'll keep downgrading the option until we find the sweet spot where you are comfortable with the side effect profile and I'm still okay with the efficacy. And we try to match up the best drug for the best person. Now, in my haste to set this up, I forgot to set up my lights, and I see there's a lot of lights behind me. So I'm going to run around really quick. Don't run away. Stay there, okay? Ready? Just give me less than 30 seconds. Ready? Go. Hopefully you can still hear me. I'm running around like a wild man trying to get this set up so I can get my lights on. I should have done this beforehand. I'm sorry that I didn't. Let's see what this is like. That's a little bit better. Okay. All right, let's try that. I'm back. I am not a videographer. I'm trying to do the best that I can with my measly medical education. What else do we have here? Amber Raver says hi to Emily. Okay, hopefully you guys can see me a little bit better now. Sky Scarlet is online. Hey, Sky Scarlet, how are you? And Sky Scarlet writes, what are your thoughts about brain-gut connection and leaky gut being the cause of autoinflammation or autoimmunity MS? So I have a video on the brain-gut connection on this channel. If you haven't seen that yet, please jump onto my channel and check it out. It's fascinating that the gut flora, the bacteria that live in your bowels, influence your immune system. That's really, really interesting information. And there's a theory that people with autoimmune conditions have dysbiosis. Dysbiosis is a funny word that means you have naughty, bad bacteria in your gut, which are negatively influencing your immune response and might contribute to autoimmunity. Now, this has not been ferreted out to the extent that we know how to treat it yet. So it probably is true that probiotics, that changing the gut flora could influence MS, except we don't know which gut flora yet. We don't know the right species of bacteria which are going to do the best job. And so that is a very active area of research. I don't think that a leaky gut causes MS, but it may very well contribute to some of its pathology. And I think that you're going to see over the next 5 years a tremendous volume of research building up about this. Now, I do think that taking probiotics is a decent idea, not because of that, but because many, many people with MS have bowel problems. It's very common in MS that you have bad constipation or sometimes difficulty controlling your bowels and having accidents even. And probiotics helps regulate that. So when my patient says they're interested in probiotics, I think that's fantastic because of what it does for the gut. But I can't tell you in good faith in 2019 that we know how to manipulate the gut flora to help with MS, not just yet. So Sherry writes in, and Sherry Steelers girl says, is it common to not want to wake up in the mornings because it hurts so much? It takes me like 4 hours just to get going. Well, here I am with my cup of grog, and I'm going to throw out a question to you guys. What do you think's in my cup of grog? Write down in the comments what you think it is, and I'll tell you when you get the answer right. People with MS, as I said in the beginning of this live stream, are at risk of pathologic fatigue. Fatigue that's very, very hard to explain. Yes, Josh, it's coffee. Yes, Beverly, this is coffee. Tracy, it's coffee. I'm a lover of coffee. Sometimes when I go to bed at night, I think, oh, I get to have coffee when I wake up. And the very first thing I do in the morning is I get coffee. Now, oh no, never decaf. Catherine writes in decaf coffee, and I don't believe in that stuff. Not for me. I take 2 medicines a day. I take an antidepressant and I take a cholesterol pill. And the way that I remember to take my medicines is I don't remember at all. I put my medicines on top of my coffee maker. Every morning I make a beeline to my coffee maker, and every morning I discover that I have medicines. So I don't have to try to remember to take my medicines because I'm addicted to coffee. And that's a technique that I use to make sure that I can remember my medicines. It's not a cold. It's the only time that I drink tea. I like tea, but I love coffee a whole bunch. Caffeine addictions are always reflected upon with such zeal. True tech, you're absolutely right. I am proud of my caffeine addiction. I'm a big fan. And so with that, let's all have a cup of coffee this morning together. Jim writes, is there any truth to the fact that raising chickens keeps MS at bay? No. Many of you on the channel know that we have chickens. I live in the city. I live in Columbus, Ohio, not in a suburb. I live in the city. And we have 7 chickens. I like to call them city chickens or urban chickens. Several years ago, my wife and I embarked on a 1-month Whole30 diet. It was really cool, and it was life-changing, actually, because the Whole30 diet forces you to contemplate where does your food come from. And in part of this process, we decided that we wanted to have fresh eggs. And so we had to get some permits. We had to have a chicken inspector. I'm being dead serious. A chicken inspector came out to the house and inspected the coop, and eventually approved us having chickens. And so in our little backyard, we have a run and we have a coop with a heat lamp out there because it's freezing in Ohio right now. And we have 7 chickens. And when it's not cold outside, they each lay 1 egg a day. And so I love having chickens. It's super fun. I like to include them in my videos sometimes. And so thank you for pointing that out. So Cheryl Clark writes, I had an MRI and 10 demyelinating scars. I'm wondering if you have demyelinating scars, is that automatically MS? So when we do an MRI, Cheryl, we're taking a picture. And I have a couple videos on my channel that explain how the MRI works and what the pictures mean. And so for those of you that haven't seen it, check out my videos on MRI and MS. The picture, when you see a white spot, it's an area where there's been inflammation. And it doesn't tell you this is a stroke, this is a tumor, this is an infection, this is MS. It's literally just a white spot. We use the size, the shape, and the location of those white spots to clarify if we think that they fit with an MS diagnosis or not. Now, if we did a brain biopsy, which I'm not recommending, if we did a brain biopsy, we could take out a piece of that brain and look at it under the microscope. The problem with that is you need that brain, so we don't want to take it out. And so I can't answer your question without better understanding you, your history, your physical exam, and looking at your MRI. But it's the pattern of the MRI, it's the pattern of the white spots that tells us this doesn't look like MS, or maybe it does. Thank you for the question. Candy writes in, any patient of yours knows that you're addicted to coffee. Candy, that's true. So for those of you that don't see me in clinic, it's my pleasure to have a cup of coffee with a patient. And I typically offer coffee or water to every single patient, and I'll have a cup of coffee with every patient in the morning. And in the afternoon, I might have a cup of coffee with every other patient. And then I call it quits around 4 o'clock in the afternoon when my stomach hurts from too much coffee. But it's true. I enjoy drinking coffee with my patients. I think it's an awesome way to have a conversation. And honestly, that's what I'm doing with you right now. So what are some other questions that have jumped up? Sarah, I'm ashamed of using my cane or wheelchair. How can I explain it to people? So let me comment on that. Someone just wrote in and said that they feel ashamed to use their cane or their wheelchair. I understand the desire to want to be like everyone else. I get that. I understand the desire not to stand out and be identified as having a disability and having someone point at you. But let me flip that upside down. How on earth could we possibly teach children that there is a vast variety of human experience and that some people need to use an assist device to be safe, and that those people are being smart because they don't want to fall down, and so they're using a cane to help them ambulate, or they're in a wheelchair because they can't walk and they're still engaged in life? How on earth can we help children learn that if people with disabilities aren't brave enough to go outside their home and to demonstrate to the world that I am a human being, I am beautiful, I am wonderful, and I happen to use a cane. I am a human being and I contribute and I have things that I want to offer, and I happen to be in a wheelchair. I want my patients to embrace the fact that they're helping change a generation of young people by normalizing, by not stigmatizing disability. And so I appreciate that it's not a fun thing and it can be embarrassing. But I want you to understand that the definition of bravery is doing something despite being scared or despite being embarrassed or despite being ashamed. And I hope that you'll think about that the next time you grab your cane and go outside, because there's going to be a family on the other side of the street, and they're going to look over and they're going to see you, the beautiful person that you are, the amazing, wonderful human, and they're going to notice that you have a cane. And the fact that you're there makes it okay. And so please keep that in mind. It's something that I feel very passionate about, and I can't improve that in our culture. You can, and I want you to please do that. Jim writes in, is the shingles vaccine safe on MS drugs? Jim, it depends on the drug. And so again, with MS patients, we don't want you to take live vaccines. We prefer dead vaccines. And many MS medicines, it's totally cool in the gang to get a shingles vaccine, but there are certain MS medicines where we have to time them right. So I can't give you a recommendation, yes or no. It depends on which drug you're on. Jim also says, how do you treat people in wheelchairs? Like people. Jim, that's a really good point. And I wanna adjust your language a little bit. He said, how do you treat people in wheelchairs? I like to say, how do you treat people using wheelchairs? See what I did there? It's not that you're in a wheelchair, you're choosing to use a wheelchair because you want to go somewhere and your legs don't work very well. So you're smart and you use a device that helps you do that. You're using the wheelchair the same way that I use glasses. So I use glasses because I am damn near blind without my glasses. And so I use glasses so that I can see better, in the same way that someone who uses a wheelchair does it so they can get along better. Alex writes in, what percentage of patients under observation awaiting diagnosis comment to you, is it a brain tumor? First thing I said to my neuro, I'm guessing 70%. It depends a lot, Alex, on the presentation. And it depends on what the MRI looks like. Now, when you see a spot in the brain, you build what I refer to as a differential diagnosis, or a list of what it could be. And that list may include some vascular things. It may include some tumors or things like that. But I really think it's kind of dependent on what the MRI looks like. Certain MRIs in MS look like tumors. And there's actually something called tumefactive MS. Tumefactive is a doctor word that means that thing looks like a tumor, even though it's not. Excellent question. Thank you for asking it. Catherine writes in, is PPMS a different disease than RRMS? Awesome question. I really like that question. I'm going to punctuate the question by having some coffee. So this is a ongoing debate, whether or not progressive MS and relapsing MS are different diseases or the same disease. And there are different camps or schools of thought. And I am a member of the camp that says it's the same disease. I think there's one kind of MS and that it can manifest differently. So some people with MS are going to have frequent attacks. Some people aren't. Some people are going to have a steady progression of disease from day zero. Some aren't going to have progression until very late in the disease. I think it's variations on a theme, and I do not believe that they're different. I want to give you an example. And this is an example of the tail wagging the dog. Someone asked about Ocrevus earlier, ocrelizumab. Ocrevus is approved to treat both primary progressive MS and relapsing MS. Maybe it's just treating the same thing. It's treating inflammation. I don't think the drug works differently in a PPMS patient mechanistically. It doesn't do a different thing than we see with relapsing MS. And I just throw that out there as a silly example of why I think they're the same condition. This is actually a really, really large topic, and there's a lot of literature on it, and I could talk about it for like 7 hours. But I'll just answer the question quickly by saying I think it's the same disease. I think people with primary progressive MS have subclinical attacks, meaning they have inflammatory damage that leaves marks on their MRI. But for the first 10 years of the disease, those attacks don't reach the threshold where they have a clinical manifestation, and they have a slow, steady decline. I think relapsing MS, same thing. It's just that their inflammation is intense enough that they have clinical attacks early on. Again, that's my biased opinion, but it's an informed medical opinion. There are doctors, there are MS neurologists that think they're separate. I just think those people are wrong. So let's jump back to the questions. Sarah says, hi, Aaron. Well, hey, Sarah, how are you? You are wonderful. Have you heard of the MS Gym? I have heard of the MS Gym. Now, this is not a plug for the MS Gym. It's a group on Facebook led by a guy named Trevor. He seems like a really great guy. And you can log on and there are exercises. And I've had several patients that have used the MS Gym and really improved themselves. It's been a great way for them to exercise. It's something that you can do anywhere that you can pull up Facebook. And so I think it's worthwhile. We have neurophysical therapists where I work at Ohio Health that direct a wellness exercise program. And so I'm very biased. I like our exercise program quite a bit. But for those of you that have Facebook, it means that you have access to the MS Gym, and you might want to check that out. Let's look at some other questions. So Dave Sargent writes, I thought it was a tumor before my diagnosis. Again, so Dave and Alec have had similar experiences. The first thing they thought is, oh, this is cancer. And then they find out it's not cancer. Is there a relationship between thyroid issues and MS? Yes, there is. If you have one autoimmune disease, you're more likely to have a second autoimmune disease. And if you have MS, you're at slight increased risk of having other autoimmune conditions. There's something special about thyroid. And it looks like people with MS are at slightly increased risk of thyroid conditions compared to the general population. It's common to have thyroid problems. And I think that it's very important that we check them. And so it's an easy thing to do to check thyroid panels. It's a set of laboratories and it gives us great information. One of the reasons it's so important to explore thyroid is thyroid abnormalities can make you fatigued. So can MS. And so if you have MS and you're exhausted, and in fact, you also have a thyroid problem and we don't realize it, we might be missing something. We might be ignoring a thyroid problem contributing to fatigue. So it is common that we can see people that have both, and we need to be on the lookout for it, and we need to treat it when we see it. Stephen writes in, with laryngeal spasms, how do I drink water without a spasm? It can be embarrassing. You're right. That's a terrible symptom. He's talking about a spasm of the throat when drinking. I don't have an easy tip for that. I will tell you that speech pathologists are brilliant men and women. They're fantastic at assessing swallowing and helping. And I would make sure that you're talking to a speech pathologist. A really easy trick that sometimes works is to drink through a straw. And so I'll throw that out there for something for you to consider. So this is fantastic. I love all these people writing in. Patrick writes in, hi, doctor, is there a limit on the amount of Ocrevus infusions one can get? I'm on my 5th in April. Ocrevus is a disease-modifying therapy intended to be taken forever. And so there's no set limit. If you look at the package insert, it doesn't say X doses and stop. There's questions about long-term use of Ocrevus. And I remind people that Ocrevus is an anti-CD20. It's a B-cell killer. And there's a predecessor, another drug called rituximab, that's been around for a long time, since the early 90s. Now, I've had people on rituximab off-label for MS for over a decade. And it's my own personal belief that this is not a drug that after X number of years you have to stop. Of course, you always have to assess the risk-benefit. And sometimes we have to make sure that the patient remains safe on the drug. But barring a safety problem, I don't see a reason why we would stop. I want you to take your disease-modifying therapy forever unless one of 5 things happen. And this is true for Ocrevus, it's true for any drug. Number 1, we are going to consider breaking up with the drug if you have an attack on the drug. So you take a birth control pill to prevent getting knocked up. If you're on birth control and you get pregnant, it didn't work. And if you're taking a disease-modifying therapy, Ocrevus or something else, and you have an attack, it didn't work. Number 2, if you have new spots on your MRI. If you're on a disease-modifying therapy and you have new spots, the drug's not doing what it's supposed to, and we have to discuss whether it's safe to stay on it or whether we need to upgrade or change. Number 3 is if your neurological exam is evolving or getting worse. If you're accruing disability despite taking your medicine, I want to look critically at your medicine. Number 4 is if you can't tolerate the medicine. And so if you're having side effects that make it awful to tolerate the medicine, then that's something that we need to think about. And lastly is the safety profile. And sometimes a drug that's safe in the beginning, later down the line, might not be as safe. And so if any of these 5 things happen, we need to think critically about your drug. Now, Amber wrote in. Amber, I think it's awesome you're online. That's really, really nice of you. And let me find what you just wrote. I'm doing this by myself. And, oh, where is Amber's comment? Guys, did you just, there it is. Some questions have come in clinic. How effective are steroid treatments? How long do they help? And how often do you recommend that you receive steroids prior to switching disease-modifying therapy? Thank you, as always, Amber. That was great of you to bring that up. So let's address what Amber's saying. IV methylprednisolone, or Solumedrol, IV steroids, it is used in MS to quell inflammation. And when you're having an acute MS exacerbation, an MS attack, a flare, a relapse, then we want to give you high-dose steroids to quell the inflammation in the brain and spinal cord and to hasten your recovery. The steroids change the behavior of the white blood cells, the immune cells, and they change the cells for the life of the cell. So basically, after you take steroids, the changes to the cells and therefore the clinical benefits can last 6 months. Sometimes when you take steroids, people immediately feel better, but sometimes they don't work right away, and that doesn't mean they're not gonna. When we administer steroids for an attack, we like to see our patients in follow-up 4 to 6 weeks later, because I want to give it time to see how much better they've gotten. Amber makes reference to transitioning from one disease-modifying therapy to another, switching drugs. And there's a lot of medical science that goes into switching drugs. Sometimes we go from one drug immediately to the next. And that's always my preference because I don't want you not on a therapy. But there are other times when it's not safe to go immediately from one drug to the next. And there has to be a pause. And I'll give you a hypothetical example. Someone on Gilenya who has moved 80% of their white blood cells into the lymph nodes is going to transition to a drug that kills white blood cells, like let's say Lemtrada. This is just an example I'm making up. We don't want to give Lemtrada until the white blood cells leave the lymph nodes and come back out of the bloodstream. And that can take 1 to 2 months. So for our patients that are on Gilenya transition to Lemtrada, in this example, we wait a month or 2 before we give them the medicine. Because Lemtrada can't enter into the lymph nodes the same way that it can in the bloodstream. And we want Lemtrada to have access to those cells so it can kill them. So what do? We stop Gilenya, and then once a month, we'll give the person a slug of steroids. And the theory here is it quells inflammation and allows us to buy time to transition over to Lemtrada. So that's just an example. Amber, thank you for bringing that up. I really appreciate it. And let's jump in with some other questions. Are the DMT safety efficacy depend on the race of the patient, white, black, Asian, etc.? That's a very interesting question. And largely, we don't have a lot of information about that. when you look at clinical trials, they sometimes will break out minority populations, not often. There's been research done specifically with Tysabri demonstrating high efficacy amongst African Americans. I have a biased opinion that interferons may not work as well amongst African Americans. I don't have science for that. I'm not telling you that's a scientific fact. I'm telling you that's something that I believe to be true, and particularly low-dose interferons, I don't want to see African Americans on. That's again my own medical opinion, and it doesn't make me right. It's something that I've developed an opinion on over the last 15 years. But we don't have awesome science, and we need to do more research looking at different ethnicities to see if one drug works better or not. There's a couple inappropriate comments on the question. Someone said, "Are you a virgin?" Well, I have children, which would suggest that I am not. That's a silly question, and there's a silly answer. Thank you for asking it, kind of. Chuck O writes, "Good morning, Dr. Boster." Well, good morning, Chuck O. Chuck is a great member of this online MS community. He's written several comments and questions, and so I love seeing you online. What else do we have here? So Marion Williams writes, "Can you have a relapse without active lesions? I had optic neuritis, and on an MRI about 7 weeks later, it showed no enhancing lesions. This meant I wasn't eligible for second-line DMT despite 7 relapses in 2 years." Well, check it out. You can have an MS attack that manifests as a clinical attack, clinically. So you have bad things happen. You can't see, or your hand doesn't work or something. And it can not show up on the MRI. So the answer to your question is yes, you can have an attack without evidence on the MRI. You can also have new spots on the MRI without an attack, because it's not a perfect one-to-one correlation. The MRI doesn't capture every single thing that happens. There can be gaps in an MRI. Many community MRIs will capture 5 millimeters of brain. They'll skip 2 millimeters and then 5 millimeters. So if there's a lesion in that area, we're not monitoring it. We're not catching it. And it is a fallacy. It's wrong. It's incorrect to assume that you have to see spots on the MRI to prove someone's having an attack. That's not true. Similarly, just because you have a new spot on the MRI doesn't mean you've had an attack. Both teach me the exact same thing. A clinical attack or a new spot on the MRI teach me that the disease is active. And if you're taking a disease-modifying therapy and you have an attack, or if you're taking a disease-modifying therapy and you have MRI activity, they mean the same thing. They mean breakthrough disease, and I'm not okay with that. But you don't need both. I don't understand, to be honest, when a neurologist sees an attack and then gets an MRI to confirm it. You don't need an MRI to confirm it. You have the human being in front of you. When you tell me you can't see, and I do a neurological examination and I find evidence of dysfunction of your optic nerve, I don't need to spend $3,000 on an MRI to prove that point. You just did it for me. In fact, I like to get MRIs when people aren't having attacks, when they feel grand, because then the MRI serves a valuable purpose of looking for subclinical disease activity, things that we would otherwise miss because they're below the threshold of being obvious clinically. Great question. Thank you for asking it. So I'm going to pronounce the name wrong. I apologize. Shirvat, I hope I didn't say that too bad, writes, "Good afternoon, sir. How can we recover myelin destroyed in MS? As drugs drugs are so that patients get attacks in MS." So I think the thrust of this question is about remyelination. I've shared this before, but in my opinion, we need 3 kinds of drugs to beat MS. 3 different kinds of drugs. Right now, we have 1 kind of drug. Right now, we have anti-inflammatories. Every MS disease-modifying therapy is essentially an anti-inflammatory. They quell new bouts of inflammation, which is very, very important. But that's 1 of 3. This one, I think we need a remyelinating agent. So when MS strips the coating off the outside of the nerve, it strips off that myelin sheath. We need something to put it back on. And there are a lot of ongoing investigations and clinical trials right now attempting to study that. At Ohio Health, we're participating in a study looking at a medicine called opisinomod. I didn't make the name up. It used to be called anti-lingo. And it's one of the most hopeful drugs. We're very, very hopeful that it'll prove that we can remyelinate. So that's an active area of research. Now, I said you need 3 kinds of drugs. We have anti-inflammation. We have remyelination that we're working on. We also need a neuroprotective agent. A neuroprotective agent to prevent the leaking pool, and we don't have that yet. And so there's a lot of ongoing investigations trying to identify remyelinating agents and trying to identify neuroprotective agents. And I really think it's going to be a triad of all 3 that can really beat this disease. So there's a lot more research that's needed. So moving along and reading a couple other questions. Alec writes in, he says, I think you deserve a biscuit with your coffee. Thanks for your energy pouring into this. Alec, thank you very much. I just had a really fun thing happen to me. The local newspaper here in Columbus, Ohio, did an article on my YouTube channel, on this YouTube channel. And if you go to the community section of my channel, then there's a link and you can check that out. And it made me feel amazing. This has been a great experience for me. And it was one of the things that prompted me to want to jump online today and say hello, howdy, hi, and talk with you guys. It's pretty early here. My entire family is asleep upstairs. My dog's asleep upstairs. And so it means a lot to me that I can jump online. And there's actually 87 of you online this very moment talking with me. And that's very, very cool. So I want to say thank you to you, Alec. I want to say thank you to the people that have made this possible. Michael writes in, good morning. I just read an article that says blood stem cell transplantation is better than DMT at reducing risk of progression. Is that coming soon? Stem cell transplantation is exciting. Stem cell transplantation is very involved, and it's not yet prime time. There's a guy, Burke, out in Northwestern that just got a lot of press because he put out a paper and he was interviewed on the news, and he's doing amazing work. And he is helping develop stem cell transplantation for MS. There are registries around the world. There's a large registry in Canada. There's a large registry in Italy. There's been stem cell transplantation research done here. I did 4 stem cell transplantations as part of my participation in a clinical trial called the HOLT trial. Stem cells is not prime time. It is not prime time. I do not want you to run out and get a stem cell transplant. It should be done today in the context of research. And I bring that up to you because there are places around the world where you can travel and give someone $25,000 and they'll do a stem cell transplant. And that's dangerous. I'm talking like it could kill you dangerous. And so I am very excited about stem cell transplantation. I think that within 10 years, it's going to become something that we use in MS routinely, and it's not there yet. So stay tuned. That's an awesome body of literature, and it's getting more and more exciting, but it's not prime time just yet. So BK Holly R writes, I've had MS 14 years, and I've been mostly stable the whole time. I still get anxious when it's time for my MRI or for a follow-up. That means that you're a human being. It's not nice having MS. And I am delighted, Holly, that you're stable. But it makes perfect sense that you get anxious. And let me share this with you in this way. Amber, who is my medical assistant, she's online right now, knows that I feel that I have to have Kleenex in my room always. And I joke that I make women and children cry. And I say that jokingly, but I have this effect on people. And the reason I think, or at least I hope, is because all year long, you're out there killing it. You're working and playing and loving and climbing and sleeping, and you're engaged in life. You come to my center, the Multiple Sclerosis Center, and I make you do MS testing, and I make you get an MRI that we're going to look at, and I make you talk about your MS. And that can be anxiety provoking because the rest of the year you're out there living life. And then I bring to the forefront the multiple sclerosis, and it can be anxiety provoking. You're smart in that if that MRI shows activity, we're going to have to make changes. And the fact that you feel awesome and look awesome and are doing well, maybe you're not doing as well if we find new spots. And so it is an appropriate response to be anxious. And I think that we just have to own that. I think we have to say, this makes me anxious. And we have to talk about it. Holly said, is that normal? Yes, it's very, very normal. Super duper normal. So Kelly Bobelli writes in, I echo, are frequent MRIs bad for your health? Oh, very good question, Kelly Bobelli. By the way, I like the name Kelly Bobelli. So MRIs are safe. They're very, very safe. The MRI does not use radiation. It is not an X-ray. It's not a CT scan. The MRI takes a picture using a magnet, a really, really powerful magnet. And again, I have videos on how this works. And so if you go to the channel, you can look up MRI playlist, and I talk a little bit about this. You can have an MRI during pregnancy. When we do this, we will do an MRI of an unborn fetus in the womb, and it's completely safe. Now, when you get the GAD contrast agent, that has to be processed by the kidneys. And so there are situations where the contrast agent might not be safe in all people. But having an MRI is safe. You could literally have an MRI once a day, and there would be no bad effects, except unless you're claustrophobic. But it's not dangerous to your health. So I've now been online for about 55 minutes. Time's gone really fast because this is super fun for me. I'm going to take another question or two, and then we're going to wrap it up. And so Stephanie C writes in, I've had 2 attacks within 6-month period as early diagnosed. Should I be worried about the frequency? Stephanie, yes, you should be worried about the frequency. Frequent MS attacks, particularly in the first 2 years, is a bad prognostic factor. Now, I'm not saying that to scare you. I'm saying that I want you to be on point. We need to make sure that Stephanie is on a highly effective disease-modifying therapy to shut down those attacks. We need to make sure that Stephanie's not smoking cigarettes, which increases the risk to have attacks. We need to make sure that she's exercising as part of her lifestyle to maintain a large functional reserve. And we need to make sure that she's supplementing low levels of vitamin D that can drive this disease faster. That was a great question. All right, let's take one more, then I'm going to wrap it up. So Brenda's online. And that question, I don't understand, Brenda. I love you. I'm not sure what that was about, but I'm going to grab another one. I'm just reading through comments here. I'm doing this myself, and I'm trying to talk and read at the same time. Not my strong suit. Let me wrap up by saying the following. You don't get to have MS by yourself. You don't. You have MS with your village. I want to be one of your village members. As you look at the 89 people that are online right now, in my opinion, they're also a village member. And I want you to have the biggest village possible. I want you to have a massive village. The more villagers, the better. And at the center of that village is the patient and the family. And then I want to include care providers. I want to include practitioners and clinicians and doctors and nurses and physical therapists and social workers. I want to extend your village to your community, to your pastor, to your rabbi, to your congregation, to your book club, to the guys that you ride motorcycles with. These are your village members. And I am of the opinion that an online village is a powerful village. And so we are your village members. You don't get to do this by yourself. Why did I want to wake up on a Saturday morning and jump online? I want to spend time with some village members, guys. And, it's not just a one-way street. Your love and my love, we share it. And together, we're better than MS. Together, we're stronger than MS. Together, we can fight this. And when you're feeling sad, blue, and depressed, I want you to reach out to a village member. And when you're feeling awesome, I want you to reach out to a village member. My name's Aaron Boster, and I started this YouTube channel to help my own MS clinic patients learn between visits. And as I like to say in my videos, it's my hope that through this YouTube channel, I can help you learn too. But it goes beyond that. It goes beyond just learning. It goes beyond that, it includes loving and sharing. And that's what we do. That's what village members do. That's what friends and families do. Until my next video, this is Aaron Boster saying thank you very much for learning about MS with me. Thank you for supporting this channel. Thank you for your comments. And I look forward to our next live discussion. I hope to do this at least once a month. So I'll see you really soon. Take care, guys. Have a great weekend.